مساء الخير على حضراتكم جميعا. ان شاء الله بقى نبتدي اليوم الثاني، والحضور ان شاء الله الناس ابتدت تيجي من بعيد. وطبعا بدعوا بقى الاساتذه التشير بيرسونز بتاعت الجلسه يتفضلوا بان هم يديروا الجلسه، اول جلسه في اليوم الثاني. اتفضل.
بسم الله الرحمن الرحيم. It is my pleasure to chair my colleagues دكتور عزة فراج، دكتور جميلة نصر، دكتور هاني الشهيدي، دكتور إيهاب الحفني، دكتور خالد النادي، دكتور خالد نبيل and me دكتور حسام الشاعر to start this session. And the first speaker will be دكتور عمرو كمال and he speak about contemporary management of hypertension. تفضل.
السلام عليكم. الأول طبعا بحب أحيي الدكتور مجدي عبد الحميد. he is a brilliant mind فعلا حقيقيا، ويعني we are all proud of him بتحقيقاته الإنجازات الكبيرة اللي بيعملها في جمعية القلب الأوروبية وفي جمعية القلب المصرية، وبهنيه على نجاح المؤتمر كالعادة زي كل سنة. السيشن عنوانها prevention of heart failure، وده طبعا عنوان كبير جدا وقيم، ومعانا مجموعة البريفنشن موجودة في التشير بيرسون وأستاذتنا الدكتورة جميلة نصر والأستاذ حسام أنديل والدكتورة هاني والأستاذ إيهاب الحفني، دكتورة عزة والأستاذ دكتور خالد النادي وطارق نجيب. احنا هنبتدي المحاضرة من الكونسبت of prevention of heart failure. Prevention of heart failure, contemporary hypertension management. The background: hypertension affects a substantial portion of the population worldwide, and more than 8 million deaths per year are attributable to hypertension. We all know that the hypertension is the single most important contributor to mortality and morbidity, and it was shown in Framingham Heart Study. The risk of developing cardiovascular disease in individuals with blood pressures more than 130/85 was almost triple that of participants with blood pressures less than 120/80. This is a graph from the Framingham Heart Study showed how is the non-hypertensive patients at low, very low risk of developing cardiovascular disease, and both isolated systolic and diastolic hypertension is at high risk, and more with the both systolic diastolic hypertension. Hypertension is the single most important modifiable factor for the development of heart failure and precedes heart failure diagnosis in up to 85% of persons. A meta-analysis of the 23 blood pressure lowering trials showed that 30% of the patients develop heart failure. 30% من العيانين بتوع الهايبرتنشن بيdevelop heart failure, which amounted to 9 events per 1,000 patients. Long years of accumulated data suggest that adequate blood pressure control can reduce the risk of moving from stage A or B to stage C. The pathophysiology of how hypertension get to heart failure has multiple mechanisms, starting from the increased left ventricular overload, neurohormonal activation, mechanical stress leading to RAS activation and sympathetic nervous system activation, leads to dilated cardiotoxicity, vasoconstriction, microvascular abnormalities, oxidative stress, endothelial dysfunction, and inflammation. All lead to ventricular remodeling and eventually to systolic and diastolic dysfunction. These are the stages of heart failure according to the American College of Cardiology, showing stage A at risk of heart failure without current previous symptoms or signs of heart failure and without a structural functional heart disease or abnormal biomarkers. Stage B is a pre-heart failure patient without current or previous symptoms and signs of heart failure, but evidence of one of the following: either a structural heart disease, evidence of increased filling pressures, or a risk factors and increased markers persistently elevated troponin in absence of competing diagnoses. Stage C is patients with current previous symptoms and signs of heart failure, and stage D is advanced heart failure with marked symptoms that interfere with the daily activities. Long-lasting staging of hypertensive heart disease starts like a degree 1, which is left ventricular diastolic dysfunction with no hypertrophy. Degree 2 is left ventricular diastolic dysfunction with hypertrophy. Degree 3 is clinical heart failure with preserved ejection fraction. And degree 4 is eccentric LV hypertrophy with reduced ejection fraction. So we have two concerns in dealing with patients with hypertension and heart failure care. We have two main issues. First is blood pressure and heart failure prevention. Could blood pressure management prevent heart failure? And second thing is managing high blood pressure in established heart failure patients, already patients who are in heart failure. So what are the targets? The blood pressure targets and heart failure prevention, we have a very long history from the SHIP, HIVET, CIST-EURO, and ALL-HAT, all showed that reduction of new heart failure events resulting from systolic blood pressure reductions to 140, 145. This was on the older people. However, the outcomes for the large randomized trials addressing the question of whether lowering the systolic blood pressure below 120 is an effective strategy to heart failure is still not fully addressed. This was also supported by the CardioCist trial and the ACCORD trial, which showed little benefit of intensive control of blood pressure, either in diabetics or non-diabetics, towards the prevention of heart failure. This was all the trials still coming, the SPRINT trial. The SPRINT trial was in 2016, and it showed a target, a systolic blood pressure less than 120 was associated with 38% relative risk reduction of heart failure. And blood pressure lowering in those patients with hypertrophy delay further remodeling and reduce the incidence of heart failure. And this, of course, has an impact in reduction of cardiovascular events, cardiovascular death, myocardial infarction, and stroke. This was the SPRINT primary outcome cumulative hazards. It shows very well the cumulative hazards goes with intensive arm versus the standard treatment, and number needed to treat to prevent a primary outcome was 61 patients. This also the SPRINT primary outcome and the components with all heart failure is reduced with significant p-value, and this makes intensive treatment reduce the cardiovascular disease composite primary outcome by 25% and total mortality by 27%, and a significant contributor to strongly positive primary outcome was 36% reduction in the hospitalized acute decompensated heart failure events. This was very supportive of how we can aggressively treat hypertension to prevent heart failure, and for every 10 millimeter mercury reduction in systolic blood pressure, the heart failure rate declines by 13%. Still, just the previous year, the final report of the SPRINT research group was published in the New England Journal, and it confirms this reduction with intensive treatment versus the standard treatment, and shown that all subgroups get some benefits from intensive treatment, either with previous kidney disease or the age, sex, race, and systolic blood pressure less than 130 was achieving better outcomes versus the conventional treatment. Heart failure and non-fatal heart failure was significantly reduced with the aggressive intensive treatment of blood pressure, and the cumulative data shown that stroke reduction by 25%, heart failure by 27%, myocardial infarction 19% reduction, cardiovascular death 19% in the cumulative trial sequential analysis of all the randomized data. So the blood pressure target and the heart failure prevention, these results demonstrated a strict control of blood pressure is useful in patients with hypertension of stage A and B. It's a strict control. Conversely, an excessive decrease in blood pressure is also a factor of poor prognosis, and the J-curve phenomena has been reported in hypertension patients with stage B heart failure. Strict blood pressure control according to the patient background is important, although the target value of blood pressure control is not clear. However, a value less than 130/80 appears to be appropriate in patients with stage 1. What about the drugs? This was the old archives of internal medicine 10 years ago. All drugs do the same, with special concern to the diuretics, the ACE inhibitors, and the ARBs, to how they prevent the progression from hypertension to heart failure. The meta-analysis recently done showed that significant reductions in new onset heart failure rates in associations with all antihypertensive classes of drugs, and currently no specific drugs is recommended for prevention of heart failure with hypertension, and patients should be treated according to the guidelines. These are the second part of the problem, which is managing high pressure in established heart failure patients. This is a more complicated issue, and all medications we know has a favorable effect on heart failure, leads to some hypotension, which can be problematic during the management of heart failure. Blood pressure in heart failure patients, the optimized heart failure, the Copernicus, the CHARM, and the meta-analysis showed that going too low with blood pressure in heart failure patients is of poor prognosis, and lower blood pressures carries poor prognosis rather than higher blood pressure in patients with established heart failure. Also, the paradigm showed that although the benefit of sacubitril, valsartan over enalapril was still evident in patients with systolic blood pressure less than 120, it was significantly more decreased than those with systolic blood pressure more than or equal to 120 millimeter mercury. And however, the findings, there is a conflict or contrast data with the prospective cohort studies, which showed that higher systolic and diastolic blood pressure and pulse pressure were associated with higher rates of adverse events among patients with incident heart failure. So we have the J-curve relationship here in those patients with established heart failure, and according to the Korean acute heart failure registry, the reverse J-curve relationship was evident between the treatment of blood pressure and the outcomes of patients who were hospitalized for heart failure, and the risk of mortality and readmission increased at low and high blood pressure, with similar trends for patients with systolic and preserved ejection fraction. So we have a J point with extreme low, extreme high is not beneficial for those patients with established heart failure, and we have the sweet spot of around 120 to 130 systolic blood pressure and from 70 to 80 in the diastolic blood pressure. So we have the trade-off between prescribing adequate doses of guideline-directed medical therapy and maintaining a lower blood pressure threshold is an issue that encounter every daily practice. And the benefit of treatment in relation to the outcomes must be weighted against the adverse effects induced by lower blood pressures. And although medications with survival benefits remain effective within a lower blood pressure thresholds, no definitive evidence is available that supports intensive blood pressure control. This is a slide shows how arterial hypertension with either reduced ejection fraction or preserved ejection fraction is treated. So with preserved ejection fraction, we have to start with presumptive heart failure therapies, inhibitors, ARBs, plus a beta blocker and a loop diuretic if the patient is congested. Then it goes for both the reduced and preserved. Then switch from ACE inhibitor ARB to valsartan, sacubitril, and if it is not controlled. Then switch from a traditional beta blocker to a vasodilating beta blocker like carvedilol. Then add SGLT2 inhibitor in all patients with systolic or diastolic heart failure. If it is not effective in controlling hypertension, we can add in the preserved ejection fraction heart failure, a calcium channel blocker, spironolactone, then thiazide-like diuretic. For the patients with reduced ejection fraction, either after all these 4 steps, to add a spironolactone or a thiazide-like diuretic, and finally add doxycycline. This is a very busy slide going with how to treat patients with resistant hypertension and heart failure with reduced ejection fraction. Also, we have to emphasize about the non-pharmacological lifestyle. Then we have to choose the diuretic, the maximum dose of thiazide type diuretic, preferably chlorthalidone or indapamide, and loop diuretic if the patient is congested. If the patient EGFR is less than 30, thiazide type diuretic, least predictable blood pressure reduction and reserve for refractory edema and volume. Then for the RAS blocker, we have to try to attempt to maximize the dose of RAS blocker or sacubitril valsartan. If use of ARNI is not possible, use large, long-acting and more effective ARB like azilasartan on only combination ARB with chlorthalidone, telmisartan, olmesartan, or irbesartan. For the beta blockers, carvedilol is the preferable, and we have to, according to the Gemini trial, to try to avoid metoprolol. For the mineralocorticoid antagonist, we can add, after these 4 steps, we can add a spironolactone or irbesartan according to the patient potassium level. Then we can add a SGLT2 inhibitor with significant blood pressure lowering at a step 2. If this is not controlling the resistant hypertension on those patients with heart failure, we can add hydralazine plus nitrate or a dihydropyridine calcium channel blocker. And final step, to focus on heart rate by baroreceptor activation therapy, renal denervation, or then central sympatholytic drugs. My take-home points is this slide. When we are treating hypertension with heart failure, we have to, in patients with stage A, we have to do a strict blood pressure, intensive blood pressure control. Okay, lowering the blood pressure is carrying a very huge amount of evidence here, according to the SPRINT, final SPRINT, and SPRINT heart, that strict blood pressure control adds very large amount of evidence here in stage A, and also in stage B, prevention and improvement of left ventricular hypertrophy and cardiac diastolic dysfunction is a key. If the patient developed symptoms of heart failure like stage C and D, target value of blood pressure and recommended antihypertensive medication depends of either he is a reduced ejection fraction or a preserved ejection fraction, and up titration of the antihypertensive cardioprotective medications to start with a small dose, gradually increase it, combine medications with different mechanisms, focusing on the onset of action and EGYHF in the blood of the same category of medicine. Thank you so much, and thank you for your attention.
Thank you, Dr. Amr, for this elegant, concise lecture. A question?
شكرا دكتور عمرو على المحاضره الجميله. بس في سؤال كده، هل لما بنيجي نسلكت الدراجز عشان الانتي هايبرتنسيف، هل في دراجز بتبقى سيلكتيف عشان تقلل لي الليفت فينتريكل هايبرتروفي اواي فروم ريدكشن اوف بلاد بريشر، يعني لها سبيسيفيك رول، فيبقى دي السلكشن بتاعها يبقى احسن من غيرها اللي ما لهاش افكت على الليفت فينتريكل هايبرتروفي؟ هل في حاجات زي كده؟
كل ادويه البلاد بريشر ريدكشن الانتي هايبرتنسيفز لها role of reduction of blood pressure itself can lead to improvement of the left ventricular hypertrophy. However, there are some drugs that have some benefit, like the calcium channel blockers. Calcium channel blockers actually is very good drugs for those patients, but you know that they have some problems also. So calcium channel blockers, RAS inhibitors, may help in left ventricular hypertrophy. There is no strict evidence on or a current recommended class of drugs that can prevent heart failure, but some drugs can be used according to the older trials. The meta-analysis showed that all drugs carry the same, you can imagine that chlorthalidone is effective in prevention of heart failure more than calcium channel blockers. So it depends on the magnitude of reduction of blood pressure. And of course, there are some drugs that you have to avoid, like the beta blockers is not effective in prevention of heart failure, but it is very effective in patients with established heart failure. Also, alpha blockers should be avoided in both normal stage A or even B, C, D. It's avoided and contraindicated to use in those patients.
Dr. Amr, it's a very nice presentation as usual. And I really feel thankful to you because you have stressed upon the lifestyle medicine, which is a part of an important part for treatment of hypertension and preventing heart failure. But I'm just asking, is not just you have stated the salt, but there are many items tackling the lifestyle medicine as an important part for preventing heart failure in hypertension patients. Another point of view, in the last guidelines about the oncology or cardio-oncology guidelines, it was stated that many cardiac patients are having cancers of different etiologies, and one of the important complications of these are hypertension, and these patients are prone to develop heart failure. Do you think managing cancer patient with hypertension will be different from other type of patients?
Sure. This is definitely different because you know that the mechanism of hypertension in those patients on anti-cancer treatment is different from drug to the other. And many of them are due to vasoconstrictions, some are due to volume overload, salt and water retention, so it depends on the drug. And knowing the drug, by knowing the drug, you will know the mechanism and you will know how appropriate the phenotype of hypertension in this patient can be treated. Either a sympathetic overactivation, either a volume overload, either a RAS activation. And it depends on the phenotype according to the drug. Each drug needs, of course, a specific treatment. I think there is a complete lecture next to me about these issues, so I will not go through it. But it's, of course, definitely different according to the drug and according to the mechanism of hypertension and heart failure in these patients.
أنا if I may comment بس على حاجة. كريم go ahead.
كريم.
هو بس في meta analysis معمول على ال comparison between the different classes of antihypertensives regarding the regression of left ventricular hypertrophy, واللي اتلقى إنه mainly الRAS inhibition هو أكتر حاجة بتقلل ال LVH. Beta blockers were the least. مش مالهمش دور خالص ولكن they were the least. تاني حاجة حكاية أنا I didn't get why beta blockers do not reduce heart failure. أنا as far as I know الوحيد اللي كان طالع وده يمكن نتيجة failures في طريقة الدياجنوزس didn't reduce heart failure في all hat study were the calcium channel blockers, وكان عليها كلام كتير إن من ضمن القصة إنه maybe they are using lower limb edema for diagnosing of heart failure. I'm not aware why beta blockers.
Beta blockers in patients with the stage 1 or stage A heart failure, as we know from the old studies, beta blockers carries a high risk of stroke. So it's not the recommended to start with those patients at high risk with the beta blockers to prevent heart failure. But if you have a compelling indication and the patient is still in stage A, which is very rare because stage A has no symptoms and has no target organ damage, it's not recommended to use the beta blockers at the first line therapy.
Could I please add a point to my knowledge that beta blockers are not prone to decrease the central blood pressure. Only one drug which is capable of decreasing the central blood pressure, this is the nebivolol. So maybe it have a relationship between the complications and target organ damage and the ability to decrease the central blood pressure.
Okay, thank you, Amr, for this presentation. I have just a remark for the results of the SPRINT trial. In the original SPRINT trial, published recruiting patients till 2015, intensive treatment actually reduced the heart failure rates compared to the standard treatment. However, when the final report published with a follow-up till 2016, actually the rate of acute decompensated heart failure increased in the intensive arm versus the standard arm. The cause is unknown, but may be attributed to the fact that some patients have declined the rate of medications or the dosage or something else. However, this is still an answer point in the sprint trial.
I will tell you why, because they said that most of the improvements of heart failure was due to the use of diuretics in the sprint. The patients who improved, who are using diuretics, chlorthalidone or indapamide or thiazide-like diuretics, those patients, those specific subtypes, they are improved. But if you revise we can go back to the slide. The final report the previous year showed improvement in all subtypes of patients as regards the new heart failure. Those Black patients, those patients with CKD, patients with previous stroke, and also female patients, which were in the previous report or the old one was borderline benefit. But for all the acute heart failure, the non-fatal heart failure was significantly reduced with a p-value of significance.
I think the risk was doubled.
No, we can revise it. We can revise it if we can go to the slides. لو سمحت. ماشي. بس I will show him the final slide just to show slides كده. طيب. ممكن بعد ما نخلصها اوريها لك مش مشكلة. اوكي. Thank you so much. اشكركم.
We'll move to the second speaker, a distinguished one, Dr. Hisham Salah, Cairo University. He will talk about LDL lowering therapy, how low is safe.
Mr. Chairman, thank you very much for your kind introduction. طبعا أحب أبارك لمجدي على المؤتمر الجميل، وطبعا أنا مبسوط جدا بالحضور، كلهم تقريبا نعرفهم وناس كلها جميلة. أنا النهاردة I was given the assignment to talk about dyslipidemia management, how low should we go. It's not a very easy task يعني. الحقيقة حسيت إن أنا we have to talk first about atherosclerosis. طالما إحنا مع الفراعنة وجنبهم لازم أقول إنه أول في التاريخ أول atherosclerosis اكتشف كان في مومياوات الفراعنة. والاستادي ديت كانت CT scan study done on 52 mummies, and they found that at least 44 of them were having identifiable cardiovascular system. Out of this 44, 20, although the mean age was in the range of 40, 20 had established calcification of the cardiovascular system. So, to start with, atherosclerosis is really an old problem. دي بس شوية صور كده تبين لنا الكالسيفيكيشن في الأورطة والإيلياكس، حاجات carotid atherosclerosis وكرونري atherosclerosis. والحقيقة إن مشكلة الكوليسترول and how low should we go was very clear from many years. Even since the multiple risk factor intervention trial showed clearly that the lower your cholesterol, the lower will be the age-adjusted cardiovascular death. Then came also the 7 countries study, which also showed clearly that there is a significant relationship between atherosclerosis and cholesterol. والحقيقة بالرغم من كل ده، وبالرغم ان احنا معتقدين انه المشكلة انه فقط the statins are the ones which lower the risk، الحقيقة القصة ابتدت من سنين قبل كده. حتى الدواء القديم خالص cholestyramine led to a significant reduction in vascular events when the cholesterol was significantly reduced. Surgical ileal bypass, which was a very old operation done also to reduce the LDL cholesterol, was also shown to significantly reduce the MACE events in such patients. وبالتالي we have the belief that سواء جاي لنا البليف ده من epidemiological studies، من genetic analysis، من clinical trials، من experimental animal trials، كلهم بيدلوا بطريقة واضحة جدا that LDL is actually a causal factor for atherosclerosis and that LDL should be our primary goal. وما جت الستاتين trials بينت لنا برضو انه the lower you go with the LDL cholesterol the less will be the event rates. لدرجة عملوا من ميتا اناليسيس ظريف جدا، عملوا a clear equation that for each 1 millimole اللي هو تقريبا 39 milligram per deciliter reduction in LDL over 5 years, this will significantly lead to almost a 23% relative risk reduction in coronary events and almost a 21% relative risk reduction in major vascular events. And if we think that the issue is related only to statins, this is not true. Why? Because also data coming from the Fourier, a PCSK9 inhibitor, and from ezetimibe in the IMPROVE-IT, and from anicetrapib, a CETP inhibitor, also showed that for each reduction in LDL cholesterol of 1 millimole, there was a 21% relative risk reduction in events. والنهارده الحقيقة in my presentation I will be answering the following questions. How low should we go with LDL cholesterol? وهل النزول بيه ده is beneficial ولا لأ؟ Is it safe to go down with this LDL cholesterol? And finally, what do the guidelines say? والحقيقة أما جيت أفكر كده هقول لكم إيه في القصة how low should we go؟ فكرت إنه في genetically determined populations and specific genes which lead to a significant reduction in the LDL in the population. فحبيت أشوف كده هل في relationship واضحة ما بين such populations having a low LDL with the event rates ولا لأ. في specific populations لقوا طبعا that there is a significant reduction in cardiovascular risks in those having lifelong LDL cholesterol reductions. وميتا اناليسيز معمول على اكتر من 300,000 واحد showing this clearly. لقوا انه تقريبا بيحصل more than 50% reduction in the risk of coronary heart disease for each millimole reduction in LDL cholesterol. ال PCSK9 mutations احنا عارفين لما بيحصل gain in function mutations ده بيؤدي الى a decrease in LDL clearance and an increase in LDL. On the other hand, لما بيحصل loss of function mutations, this leads to an increase in the LDL receptors مما يؤدي في النهاية إلى a reduction in LDL cholesterol. أما جم بقى نشوفوا إيه العلاقة ما بين ال PCSK9 mutations وحدوث coronary events، لقوا إن PCSK loss of function mutations provide genetic validation for the potential role of PCSK9 inhibition in LDL cholesterol and clearance, and that such reduction بالرغم انه ما كانش كبير قوي usually in the range ما بين 13 ل 28%, this led to a significant reduction in coronary artery disease events versus those who were non-carriers. ونفس الكلام different studies كلها لها علاقة by inactivating mutations في الجين المشهور بتاع نيمان بيك اللي هو مسؤول عن امتصاص الكوليسترول from the GIT. لقوا برضه ما بيقل الفانكشنز بتاعة such a gene بيحصل a significant reduction in LDL، وإن كانت numerically بيحصل فيها reduction in event coronary artery disease events ولكن did not reach statistical significance، ولكن it is also going in the same directions. On the other hand, lifelong exposure to low LDL due to single nucleotide polymorphisms سواء نتيجة بقى different genes كلها ماشية في الاتجاه بتاع reduction in coronary heart disease risk. طب how low بقى نوصل لكام؟ يعني نوصل ل 20 ولا 40 ولا 60 ولا احنا عارفين from the 2016 guidelines انه it was a class 2B recommendation that when the LDL cholesterol goes below 40 we should be decreasing or we should consider decreasing the dose of statin to half. بس دي كانت 2016. This was not replicated again in the 2019 guidelines. بس احنا عندنا evidence اما في البروفد ترايل اللي كانت على acute coronary syndrome اكتر من 4000 عيان، اما ال LDL cholesterol نزل ل 62 versus 95. This was translated to a significant 16% relative risk reduction in events. فواضح ان نزول ال LDL ل 62 was good. On the other hand في الامبروفد لما ال LDL cholesterol نزل ل 53 لقينا انه ده كان احسن من اما كان قرب ال 70 69 ونص. And this was also translated to a significant 7.6% relative risk reduction in events. On the other hand لما جت الفورير وكان الميديان LDL cholesterol went down to 30 milligram per deciliter, this was translated to a significant 15% relative risk reduction in events. فاحنا واضح ان حتى بنزول الكوليسترول ل LDL cholesterol ل 30 this was something good. والحقيقه انه في الفورير برضو لقوا انه 2% من البوبوليشن which was almost 500 patients ال LDL cholesterol بتاعهم نزل تحت ال 10 ملغ بير ديسيليتر. وفي كام عيان حصل ان ال LDL cholesterol بتاعهم نزل لزيرو. طب هل الناس لما نزل ال LDL cholesterol بتاعهم لتحت ال 10 ال cardiovascular efficacy was reduced؟ ابدا. cardiovascular efficacy was significantly maintained. طب هل السيفتي was affected؟ ابدا. safety was significantly maintained. يمكن كان في عيان واحد حصل له neurological syndrome when his LDL cholesterol نزل تحت ال 15. وعشان كده في الديزاين بتاع الاوديسي ترايل اللي هي كانت another PCSK9 inhibitor اما جم يعملوا الديزاين قرروا اما ال LDL cholesterol ينزل تحت ال 25 to half the dose of the PCSK9 من 150 ل 75. وقرروا انه لو ال LDL cholesterol نزل تحت ال 15 to stop the dose الجايه بتاعه ال PCSK9 inhibitor and to check it once again after in the following dose. هنا ده كان تيم ستادي جروب عملوا حاجه ظريفه جدا. شافوا ال LDL cholesterol تحت ال 40. ايه اخباره بقى؟ الكارديوفاسكولار benefits are they present or not؟ فلقوا ان زي ما حضراتكم شايفين كده the line is going down and down. ان ال post hoc analysis for the Fourier showed a strong relationship between achieved LDL at 1 month and adjusted cardiovascular disease seen down to 0.2 millimole اللي هو ال 10 ملي اللي انا قلت لحضراتكم عليها. ولكن ما ننساش that this was a post randomization association. فعملوا conceptual approach. ايه ال conceptual approach اللي قالوا يمكن احنا مش القصه، يمكن لو نزلنا ال LDL كوليسترول من فوق ل 40 يعني مثلا من 2 ملي مول ل 1 ملي مول ده يكون هيعمل ال 20-21% اللي احنا متوقعينهم. بس يمكن لو نزلته من 1.5 لتحت ال 40 ل 0.5 يمكن يؤدي الى a significant improvement ب 20% زي اللي قبله او ما يؤديش، يؤدي مثلا ل 10%. فجم شافوا كده قالوا هنحط اللاين اللي تحت ده if consistent benefit of LDL cholesterol is there فالبنفيت هيكون موجود whether the LDL cholesterol احنا نزلناه ابتدينا من لغايه اما نوصل لتحت ال 40 ولا لا. واذا كان الاسامبشن is not right فاللي هيحصل انه لما ال LDL ينزل تحت ال 40 probably will not be on this solid line. بس الحقيقه ان هم لقوا ان whatever the LDL cholesterol حتى ما بينزل لتحت ال 40 there was a significant benefit in favor of lowering the LDL cholesterol and they concluded that there was no evidence for attenuation of the clinical benefit of lowering LDL cholesterol below the 1 millimole or the 40 milligram per deciliter اللي احنا عارفينه. وفي نفس الوقت احنا عارفين on the other hand انه the lower your LDL cholesterol by IVA study the probability انه يحصل regression of atherosclerosis will be more as we have seen from the GLAGOF study, as we have seen from the Saturn arm of rosuvastatin, as we have seen from the asteroid and further other studies. Finally, safety issues. هل اللو LDL cholesterol ده safe ولا مش safe؟ اول حاجه الكانسر ريسك. الحقيقه هم قعدوا يشوفوا الكانسر والسايت سبيسيفيك كانسر، فلقوا الاتي. لقوا that there was no difference, significant difference in cancer risk in this cholesterol treatment trialist collaboration. شافوا هل بيحصل hemorrhagic stroke ولا لا؟ لقوا انه حصل a slight increase in hemorrhagic stroke with the more intensive statin therapy. فده كان one signal. جم شافوا the risk of diabetes، فلقوا ان the risk of diabetes was slightly increased with the more intensive statin therapy. However, this risk was quite low with benefits which were much more. ولقوا في نفس الوقت that there was no clear evidence of memory impairment on statin therapy below cholesterol LDL cholesterol 30. الجايد لاينز بتقول ايه؟ الجايد لاينز واضحه جدا. The higher the risk of the patient, the more you should be aggressive. واحنا الليفل بتاعنا عايزين ان ال LDL في ال very high risk patients سواء primary او secondary prevention يمكن ال level of evidence مختلف but the class of recommendation is one. ان احنا عايزين ان يحصل significant reduction of LDL cholesterol by 50% and the LDL should be below 55. ويمكن it's a class 2B بالرغم ان انا اعتقد in the coming guidelines this will change لاعلى من كده لاحسن من كده، انه في اذا كان بيجي لهم 2 vascular events within 2 years ان ال LDL cholesterol يكون تحت ال 40. So start early the concept, treat aggressively. وطبعا اكيد هيكون في combination therapy. مش هضيع وقتكم بكده، بس انا برضو احب اشير ان احنا في جايد لاينز مصريه او جايدنس مصري عاملينها انا والدكتور خالد شكري والدكتور حسام انديل ومجموعه جميله جدا. We are endorsing برضو ارقام 55 في ال very high risk patients. And my key home message is that current guidelines acknowledge the importance of treating high cholesterol to reduce atherosclerotic cardiovascular risk. Evidence for statins exists for both primary and secondary prevention. LDL cholesterol is the main therapeutic target. Statins are the main therapeutic agents. Achieving even lower LDL in high-risk populations further reduces the risk and appears safe. Thank you very much.
Dr. Hisham, thank you for this very nice presentation. I'll give you a scenario of one patient. We got one patient. He was given PCSK9 inhibitor. Went down, his LDL went down to 20. But the patient is still getting an atherosclerotic attacks, acute coronary syndrome, interventions, stent implantations. What do you think we can do for him? What do you think? What are the facilities we have to help that guy? This is number one question. The second.
طب خليني اجاوب على الاول وبعدين.
لا, it's related.
Okay.
It's a B type of question. Is there any information regarding the mechanism of action of the PCSK inhibitors which may affect the future events of the patient, although they will lower the LDL to the same level? Thank you.
First of all, احنا في حاجات بنقدر نعملها اللي هي ان احنا نوطي ال LDL كوليسترول، بس احنا عارفين there are other players من ضمنهم اللايبوبروتين little a. فده should be checked بالذات in such patients who are having recurrent events. دي حاجة. تاني حاجة definitely القصة is not always only dyslipidemia. في other players. Is he smoking ولا لأ? Is he having some other risk factors that we don't know about ولا لأ? Is he borderline diabetes ولا لأ? فأنا قصدي playing on all the risk factors و checking the little protein A. I think this is the way to go. وطبعا في النهاية some people are having increased thrombosis. يعني في عيانين بيجي لهم increased thrombosis نتيجة thrombophilia أو كده. This is also one of the issues that should be tackled. فكرة إن ال PCSK9 may be acting through some other mechanisms apart from lowering LDL cholesterol. هو احنا عارفين إنه هو ليهم برضو بعض ال pleiotropic effects، بس كلها حاجات speculative. يعني ما فيهاش حاجة solid evidence that we have.
Dr. Hisham, thank you. The message is clear that we should go as low as we can so long there is a tolerance for.
طب ممكن أضيف حاجة؟
اتفضل فندم.
أنا عايز أقول إن إحنا to go low بس ده لازم يكون في العيانين اللي those who are at a very high risk. يعني انا مش هكمبرومايز العيان واحد عنده his at moderate to high risk وابتدى السي بي كي بتاعه يعلى شويه او ابتدى يجيله ماسل ايكس او ابتدى يحصل له، مش هستنى واخليه لازم اصل عايزه ما عنديش مشكله انه يبقى 20. لا، I will go by the guidelines. بس في ال very high risk patients I don't have a problem ان عندي العيان يبقى ال LDL بتاعه 20 او كده.
طيب يعني انا هو ده ما كانش سؤالي، بس بما ان حضرتك فتحت السؤال، السبيكيوليشن يعني بما ان حضرتك فتحت النقطه دي، السبيكيوليشن بتاع برونويل اللي هو الاماونت اوف اكسبوجر does it go for the high risk patient ولا for all population؟ if it goes for the all population يبقى definitely the lower the better irrespective of the risk level of the patient. Am I right?
You are absolutely right. It goes for the whole population. بس خد بالك this is an assumption.
Yes.
But I think it's a right assumption. وهي الفكرة بس ان هو قال انه مع وجود ادوية بتتاخد مرة او مرتين في السنة، فاحنا we will be having the chance to treat such patients without hassles.
Okay.
فهو حتى المكتوب ان هو he recommended that giving inclisiran once yearly,
Yes.
starting at a very very early age. فهي الفكرة بس انه يعني I agree with انه decreasing the different risk factors واولهم الديسليبيديميا، لان الديسليبيديميا دي مش حاجه هينه، خلاص احنا عارفين ان هي زيها زي الهايبرتنشن والدايابيتس، واعتقد انه physicians know this and patients also started to ask about this.
طب اسال سؤالي بس يا دكتور هشام، بس انت فتحت
خد بالك في دكتور حسام وفي
محاضره جميله ما شاء الله.
تمام.
My question is if we have the tendency to go solo, I'm very eager to know your experience as a head of the working group of dyslipidemia. Do you go for the sequential approach or do you start with all together? And if you are starting with the all together, do you use PCSK9 modifying agents from the start?
سؤال جميل جدا طبعا يا خالد. في كلام رسمي والكلام اللي مش رسمي. الكلام الرسمي ان حتى في الجايد لاينز اللي نزلت في 2022 الامريكان، ونازله مش على الستاتنز ولا على الليبيدز، نازله على اليوز اوف نون ستاتنز. هم كتبوا ايه؟ they recommended giving statins، ولو العيان did not respond to check that he is on high intensity، to check تاني يعني في المربع اللي بعده to check high intensity and ان هو بياخد high intensity وفي نفس الوقت لايف ستايل، وبعد كده consider ezetimibe وكده. In my clinical practice I calculated، يعني انا بادي مثلا ب LDL 170. I'm not expecting if I want an LDL to be below 55 that by giving high intensity statin that I will be reaching my goal. So in this type of patients, I will be starting with a combination. In spite, I know that there is a significant variability in the response to statins. دكتور حسام.
خلينا نسمع السؤال الفلور الأول.
Statin therapy is long-term therapy for life treatment.
السؤال الصعب is it for life؟ اما بتسأل السؤال ده بقول probably. ليه؟ لان احنا عارفين ان كل يوم بينزل حاجات جديدة and the guidelines of today will not be may be different عن الجايدلاينز اللي نازلة بعد شهرين. وحاليا احنا ما كناش نطمع من سنة ان يكون في دواء بيتاخد بانجكشن كل 6 اشهر، دلوقتي بقى فيه. فأنا I think إنه كلمة for life will not be accurate، ولكن حيث إن أنا عايز يكون في إن العيانين يتبعوا النظام العلاجي، وإنه